Okay, for the sake of time, I'm going to go ahead and get started to kind of go over some of the things that I was just briefly talking about for those of you who are not here for the first lecture. This is the second lecture of a 4-lecture series. Last time we sort of laid the foundation for the remaining 3 lectures. If you want, and I would encourage you to do this if you're going to view the remaining lectures either online or in person, you can go to the Biostatistics website. You can go to the main web page for KUMC and type in Biostatistics. It'll bring it up. Or you can actually just type in biostats.kumc.edu. You can find the link to these recordings under Events and Lectures. Introduction to Biostatistics for Clinical and Translational Researchers. And it will take you directly to a place where you could register. And I hope that each of you registers as you come in the door so we can send out evaluations and also to get your feedback to help enhance the course for next year, but also to keep you updated if we ever do other events like this that we think you'll find useful, and to remind you next year when the course is being taught again. But if you click on the lectures, it'll take you to the recording of the video. So after today, sometime this afternoon, you'll be able to view both last week's lecture and this week's lecture. Any questions? Today we're going to talk primarily about experimental design. So if you're designing an experiment, what are the things that you need to consider? What are the types of designs that are possible? What are the limitations for each type of design? What are the benefits for each type of design? And what are they actually telling us? How do we interpret evidence from them? And then we're also going to talk about things to keep in mind when you're critically evaluating the literature. So if you're looking to do your own study, you have to first go and see what's been done related to your research question and what's been published. There will be published and unpublished evidence, but so I'll give you some generic sort of questions that you can ask yourself about either published or unpublished research, and hopefully provide you with some references that you guys can go and read that I've found very useful whenever I try to figure out how do I evaluate the literature myself. Next time, the next 2 sessions will be what you all probably think of as statistics. We'll really dive into examples, real examples, using group comparisons, whether it be on a binary, like a yes-no outcome, or a continuous outcome. So we'll do things like a chi-square test. We'll do t-tests. We'll do analysis of variance. We'll do linear regression. We'll do survival analysis. If you have any specific references that you're struggling with where they use a particular method, I encourage you to email them to me. Again, my email address is very simple, jwick@KUMC. I sort of tweak this every year to try to enhance the not only the content but the examples based on feedback from the previous year. So if you guys have feedback at this date, if I have time, I can try to incorporate some of what you all have. So last time, again, was primarily just a vocabulary lesson, trying to get you to start thinking about research like a statistician. So we talked about what the role statistics actually plays in medical research, what is the goal when we use statistics. We did a brief introduction to hypothesis testing, so we defined error rates, we defined the null and the alternative hypothesis. We talked about the process of using hypothesis testing to choose between a theory and data, which is empirical evidence. Again, we'll cover that more thoroughly starting next time. We briefly touched on concepts in design, which we'll cover today, and we talked about descriptive statistics. So if you recall, I thought it was right here. The field of statistics really can be broken down into 3 different parts. Descriptive statistics, which allow us to summarize the data using graphs and numbers. We talked about that last time. Design of experiments, which is really, you have to take into account what can I do for my research scenario in order to minimize bias, really is what you're trying to do. That's the whole goal of design of experiments. And then inferential statistics, which involves hypothesis testing and things like confidence intervals. So last time was descriptive. Today will be this middle box. The next 2 lectures will be inferential statistics. So let me go back. Quality of evidence. I've used this in the past. I think it's a hilarious cartoon. Today's random medical news from the New England Journal of Panic-Inducing Gobbledygook. This sometimes feels like what's actually going on, like someone's just standing behind the scenes and spinning to randomly choose a cause, an effect, and a population. Of course, that's not what's happening, but it can feel that way. You know, if you're a parent, I have children that span from age almost 14 to 7 months. What was recommended 14 years ago with my first infant, actually, some of that stuff is now highly discouraged for my third child. So things change as new evidence is generated. But the big question we have, why is there so much conflicting evidence? Even in the published literature, you'll find conflicting evidence. It turns out there's a whole set of literature out there about this problem, in particular for medical literature. There was a really great talk given by one of our investigators at KU several years ago about the way physicians think, and I've taken this graphic from his PowerPoint to talk about how decisions are made. And the fact that much of what we do, medicine, even just research itself, is an art and a science. So there is some scientific foundation, your training, the principles, the evidence, but there's always some level of judgment before a decision is made or a conclusion is made. If anyone wants to see these slides, I encourage you, if you didn't see the talk, to contact Gary. It was a very, very good talk. So the answer is there's no perfect research study. Every study has limitations. Every study has context. If we take a result out of context and we fail to talk about the limitations, whether it be design-based or population-based limitations, then we will very often see what appears to be conflicting evidence from 2 sources of information. Another unfortunate problem is that the literature is full of poorly designed, poorly executed, and improperly interpreted studies. So we need to identify those with the questions I'm about to show you. Hopefully we can identify them. And then critically evaluate the merit of the study and either discard it or pull it into our pile of good evidence. So to look at this statement that the literature is full of poorly designed, poorly executed, and improperly interpreted studies, there's a lot of articles I'll show you in a moment that deal with certain aspects of this, but I went into clinicaltrials.gov and I pulled out every clinical trial that had been registered and results had been reported for since clinicaltrials.gov started. So the first study that was in there actually started in 1976. Obviously that was before, but it had been reported. The results had been reported in clinicaltrials.gov. And I wanted to see what was the average size of the study for studies that are being put into or registered in this database. This is a little bit different because a lot of these studies have not been reported in the literature, and we'll talk about that issue in a moment. What you'll see here, they classify their studies 2 ways. What they call interventional, which is really what we have called experimental. So they are they are assigning subjects to treatments or conditions. And then what we call observational. It's not surprising that we see here in the observational studies that we have larger sample sizes. These tend to be those really long, just longitudinal cohort studies, for instance, they follow people for 50 years. They get thousands and thousands and thousands of subjects. Let's ignore that for a moment. Let's look at the experimental. By the way, the experimental studies constituted about 95% of the studies that I pulled out of clinicaltrials.gov. It may not look all that shocking until you look at the y-axis. What I had to do to make this even look like a box plot was take a log transformation of enrollment. And what the log transformation does is it spreads the data out so I can see it. Otherwise, I wish I would have put in here what the original box plot looked like. It was basically a line at 0 and then dots for outliers for some larger studies. It turns out 50%, over 50% of the studies that I pulled out, and there were 13,000 something studies in here, that were experimental, meaning the PI, the investigator, had some control over the experimental group that the subject went into, had total enrollment of less than 80 subjects. And that's small. So not only are we reporting more frequently very small studies, but we're doing small studies more frequently. Now there's a lot of different things here we could talk about. There's a lot of reasons why a study would be small, but this is a concerning issue, that we're really not doing a lot, that the majority of the studies that we're doing are small. The majority of the studies that we're reporting are small, and we're failing to progress in that scientific method cycle from small studies to larger, more definitive studies, and then replicating those results. If we did that, we would actually minimize the chances of getting conflicting evidence, because the evidence itself would be much more valid. I have a reference here at the bottom, a very, very good reference. It's a little bit more mathematical. So if you understand something like an odds ratio or a relative risk, you could understand this article. But basically, the author talks about why you really can't believe everything that you read, even when it's published. And he comes to conclusions, really in bullet points, that there's obviously this issue called publication bias. This is a second reference, not the one that I'm referring to, but the primary author on the previous one is a co-author on this one. And it talks about current publication practices and how they can actually distort science. So if you think about it, when you're doing your own research, when do you get excited about publication? What do you have to see usually? A significant result, right? If you don't have a significant result, do you still try to publish it? You should. You should publish everything. Everything. In fact, pharmaceutical companies are making a push to publishing all results, negative or positive, because they have recognized that they're doing a disservice to themselves and to other people when negative results are not disseminated. So publication bias, you can find this in lots and lots of references. People have studied this extensively. I have a figure later that I will show you about this. They have a tendency to submit, and journals have a tendency to publish, so it's not all on the authors. It's also the onus is on the journals as well. Positive studies over negative ones. We also get really excited about positive studies, and we publish them quicker. We try to get them published quicker. Journals also publish them quicker. Negative ones do get published, but the time to publication is much longer, and the chances of publication are much smaller. There's an issue with undersized studies, so there's a lot of really small studies, and we'll talk about some issues with having studies too small and how their conclusions can be not quite as clear or valid in some cases. Small effect sizes, multiplicity in testing. Multiplicity in testing means that you went and you did some fishing. You have a lot of data. I'm going to do a clinical trial, and I'm going to collect every piece of information on these people I can find. That way, I can get 15 publications and publish anything that I think of in the process. Not necessarily, you're not a priori designing your research around specific questions. You create questions based on what you see in the data. That's not necessarily multiplicity, but that's very often where multiplicity becomes an issue. Conflict of interest is huge, so we're getting better about that, about having to state whether or not we have a conflict, whether it's financial or otherwise. Hot topic areas. People are competing to be the first to show that X causes Y, and they know that they're competing with 50 other research teams, so you're going to cut corners, and that can cause an issue. Also, not having really tight, clean language about the design, the outcome definition, or even the definition of the population you're looking at, and then the analytical modes that you have. So from this reference, I encourage you to take a look, and if you need me to email you the reference, I can. He has a great discussion of when you tend to see, or what increases the chances of having a false research finding. And there is the reference itself. The summary, you could even just read the summary, and it's pretty impressive. Actually, it's pretty scary, but it's an impressive analysis to show. So how do we critically evaluate the literature? Or some of these questions you could ask yourself when you're actually designing your own research. You have to look at the validity of the manuscript and the relevance. And then in the context of that, ask some questions. So the article that you're evaluating, is it from a peer-reviewed journal? What's the quality of the journal? I would even argue not even looking at the impact factor, because that can be swayed by some things. But is it a peer-reviewed journal with a good reputation? That doesn't necessarily mean that it's going to be a quality study, because those will still slip through. How does the location of the study reflect the larger context of the population? Geographical location plays a role. So for instance, if the study was performed in Asia, it may not generalize to the United States, to what you're doing. Does the sample that they have collected reflect the targeted population? If I'm doing a research, an observational study in a VA hospital, but I'm generalizing that to the U.S. population, there's an issue with that. Does everyone understand why? What does the VA population, the population being treated by the VA, tend to look like? Yeah, they're typically male, predominantly male, and the age is a little bit higher. So there would be an issue with that. Is the study sponsored by an organization that may influence the study design or results? That may be a little bit difficult to find, believe it or not. There have been some really high-profile issues in the past 20 years that I can think of where it appears that individuals kind of come out either for or against a particular therapy or pharmaceutical, and then you find out later, after they've totally destroyed something, that they were being paid by someone who had a financial interest in something failing or succeeding. So huge issues with conflict of interest. Then look at the intervention. Is it feasible, and is it available? In terms of intent, you need to identify what the intent of the study was. There are many different reasons for performing a clinical trial or medical research. You could be testing the efficacy of a drug, which we typically call a therapeutic trial. Those tend to be, and should be, the gold standard, a randomized controlled trial, so RCT, randomized controlled trial. Diagnosis, so you're trying to demonstrate whether a new diagnostic test is valid. Those tend to be done in what's called a cross-sectional survey. Suppose there's a gold standard way of diagnosing a condition, and you have another tool that maybe is less invasive or less costly, and you want to show that it's just as valid as the gold standard, then you would simply grab a cohort of diseased subjects and some that are healthy. You would run both the gold standard, which would tell you what we would call, quote unquote, their true disease. There's always some issues with the truth behind a gold standard because they can also be fallible. And then you would run and diagnose them according to yours at a single point in time. And that's what we call cross-sectional. And again, I'll get into that design in a moment. There are limitations with cross-sectional studies, so we have to make sure that we understand the intent and how that would affect the conclusions and the limitations in the context. Screening, also cross-sectional. Prognosis, this tends to be what we call a longitudinal cohort study. Prognosis, determining what is likely to happen to someone whose disease is picked up at an early stage. And then causation, sort of exposure, epidemiological type of study, determining whether a harmful agent is related to the development of an illness, and that tends to be a cohort or case control. And I'm throwing these terms out here. I will define for you each of these types of designs. Now, is it valid, once you've determined the intent of the study, is it valid based on the intent? So, did they tell you what the study design was? Were they clear about it? Is it appropriate and optimal for the intent of the study? So are they trying to do a therapeutic study, testing the efficacy of drug treatments, and they're not using a randomized controlled trial? That's an issue. Are all participants who entered the trial accounted for in the conclusion? They say they screened 1,000, they enrolled so many, they treated X and Y, but the outcomes they're reporting are for much smaller numbers. What happened in between treatment and outcome? What protections against bias were put into place? So again, I want to emphasize here, if you walk away with one new thing, it's that we design studies to minimize or eliminate, hopefully eliminate, bias. That's the whole key behind design of experiments. Eliminate bias and actually get a valid estimate of a treatment effect. So, the things that eliminate bias: blinding, adequate controls, and there's lots of different types of control groups which we'll talk about for different purposes, different types of bias. Randomization, which we talked about last time. What does randomization do? Remember the example that I had about the workplace toxin. So some were exposed to the toxin, some were not. And then there was this other variable, which was also an exposure, but we didn't care about it, but it was there. And it turns out that that other variable had an impact on our outcome of interest, which was time to conception. What would randomization have done in that case? What would it have controlled against? What was causing bias? You remember the name, the term for that type of variable? A lurking variable, a confounding variable, a nuisance variable, right? It's a variable that affects or is associated with our outcome of interest that we really don't care about, but could cause us to basically draw the wrong conclusion. It could cause noise in the data, or it could cause bias in the data, which would make us, what we showed is it made us think that this workplace toxin actually prolonged time to conceive, when in fact the toxin had nothing to do with it. It was the other exposure that was driving the prolonged time to conceive. So we would have made what's called a type 1 error, right? We would have concluded that there was an association when in fact there really wasn't. So all of these things that we do protect against bias, and we'll go into some examples later. If there were treatment groups, were the subjects in each of the groups homogeneous? Were they similar at the start of the trial? So if you look at a manuscript, there's always that table 1, baseline characteristics, whether it be clinical or demographic or both. If gender could play a role in the outcome, did you have about the same number of males and females in each group? Or were all the males, or 80% of treatment A male and only 20% in treatment A female? And if so, is that imbalance across groups? That could be a confounding variable if that's the case. Were the groups treated equally aside from the actual intervention? Meaning the only thing that differs between subjects in group A versus subjects in group B is the intervention itself. So they looked the same at baseline. They were treated the same through the study, observed the same. The only thing that was different was the intervention itself. If that's the case, then at the end, if you see a difference, what could you attribute that difference to? The treatment, right? Nothing at baseline, no other differences throughout the course of the study. If the results are statistically significant, are they also clinically meaningful? And I should preface this by saying, do they give you enough information to determine whether they're clinically meaningful? I talked about this last time. You can't just report a p-value. The p-value does tell you that this result is statistically significant, but I can make any result statistically significant if you give me enough resources, enough subjects, enough time, enough money. Because the p-value is directly related to the size of your study. The bigger your study, the greater the chances that you'll find something, even if the result is not clinically meaningful. You could be finding noise. If the study is negative, meaning they didn't show a statistically significant result, we have to determine whether or not that's likely to be a true negative result, or was it an error? And an error could have happened because maybe they chose the wrong outcome. Maybe they're using an outcome that's notoriously noisy. It's not very specific to what you're trying to measure. Or it could be that they were doing a test in a study that was really too small to detect anything meaningful. That would be called a type 2 error, where you conclude that there is no effect or no association when in fact there really was. Were there any other factors not accounted for that could have affected the outcome? So think about, when you're reading the literature, what other things should the investigators have thought of that could have been associated with the outcome that they're thinking of, that they're actually reporting, or could have affected the outcome itself? And if they didn't talk about how they accounted for it, either in the design by limiting their population to only females, or limiting their population to only premenopausal females, if menopause, for instance, in breast cancer could have an impact, or if they didn't talk about, if they didn't even measure the outcome, then they really can't do anything about it. They don't know. It's just a limitation. They would have to discuss it in the limitation section. Or maybe they actually included it in a statistical model to try to adjust for its effects. So make sure that they've considered all possible known nuisance or lurking variables. Another good reference here from 2006. Has everyone heard of the Cohort guidelines? For those of you in particular who do clinical research. I don't specifically cover the Cohort guidelines. The Cohort guidelines are for investigators who are trying to publish the results of their clinical study. But they're also really, really good for critically evaluating the results in the literature. So if you take the Cohort guidelines, which is literally just a checklist, and you look at the manuscript and you say, okay, they did all of this, oh, they're missing this, they're missing this. That will kind of tell you about the value of the manuscript itself. If they followed the consort guidelines, they're being transparent. And you could then go further and say whether or not there are any limitations they didn't discuss, or whether or not the conclusions they drew were valid based on the type of design that they used. If you just go and Google consort statement, they have consort guidelines for different types of studies. The one that I'm most familiar with is the randomized controlled trial, because we cover that in the clinical trials class. But I encourage you to look at those. Use them for your own research. In fact, a lot of really good journals, if you look in the author guidelines, tell you you have to publish according to the consort guidelines, and they give you the link to it. But go download that when you're trying to publish your results, or whenever you're looking for really good evidence from the literature. It allows you to critically evaluate it. Any questions about evaluating the literature? Any specific issues that you guys are having that you'd like to discuss? Okay. Now we're going to get into actual experimental design. We're going to define some terminology, talk about how we would control for things, how we would minimize different types of bias, and then just some fundamental principles when it comes to designing research studies. The key point that I'd like to make is that statistics, it may have a reputation for it, but it's not magic. It really cannot rescue a poorly designed study. So if you did not design your data collection instrument to collect data in the right way to answer your research question, it's possible that you will not be able to answer your research question. I could give a specific example without naming organizations or names, but they were interested in looking at something on a county-wide level in a state. And this is not Kansas, let me preface that. But part of the state does have a lot of rural area where there's not a lot of people. So there's a manager for each county. In highly populated regions, there's one person manages one county. But when you get out to other parts of the state where there's not any people for 100 miles, there may be a single person managing multiple counties. Well, what the researchers failed to do was identify that issue. And when they collected the data that had to do with they were going to implement a new policy, they collected it at the county manager level when they were really interested in data at the county level. So if they didn't have that issue with one manager for multiple counties, then that wouldn't be an issue. But they didn't consider that when they designed their instrument. If they had, what could they have done? They could have included a field on the instrument, which was electronic, that said which county is this for, rather than associating it with the ID of the manager themselves. So it's a little bit of a difference in terms of what they could actually do with the data once they got it. And this was lots and lots and lots of money for a state-designed sort of evidence-based policy implementation for county managers. So think about those kinds of things. The measurement that I'm recording really needs to come from what? What level? Is it at the hospital unit level? Is it at the county level? Is it at the state level? Is it at the individual subject level? And make sure that you can actually capture it that way. No matter how efficient, statistical analysis can't be done overnight. I will say some of it can. But what really takes a lot of time, up to sometimes 80% of the time that it takes to do an analysis, is cleaning the data, making sure the data is all there and accurate, and then getting it structured in the way that it needs to be fed into the software. That takes a lot of time. So you may think, oh, a t-test, I can approach statistician A to do this 2 days before my poster's due. Maybe, maybe not. It depends on how much of a relationship you have with that statistician, whether or not they'll be willing to stay up overnight and clean your data for you. A researcher should be transparent. Plan, state what you're going to do it, and then report those results. So as long as you have transparency, then you're doing a service to science in general by letting others critically evaluate you. So, design of experiments has several goals, or several pieces of the larger picture. It involves formulating hypotheses, determining the experimental conditions or the treatments, the treatment groups, what measurements you're going to take. So what outcome am I going to use? Usually there's multiple outcomes for one particular thing that you could have under consideration. Which one's the best? Any extraneous conditions to be controlled for. That's why we talk about things like inclusion and exclusion criteria to limit your study, to make your subjects homogeneous with respect to, for instance, confounding factors or nuisance variables. Sample size calculation. So specification of the number of subjects required, also the number of subjects available, because if you require more than are actually available, that could be an issue. The population from which they'll be sampled, which has a lot to do with how you'll generalize your results later. The procedure that you have for assigning subjects to the conditions. So if you're doing an experiment, if we keep with the language we've been learning the last 2 weeks, if you're doing an experiment, then you're actually assigning treatment or conditions to subjects. You may be doing a study, which is observational, where you're not assigning subjects to the different treatment groups. And that would still fall into experimental design. It would be more about how you would interpret the results at the end, because you, again, have to do it in the context of the design. So all the things that I'm going to talk about today can be for both experiments and observational studies. The analyses would be the same. It would be the limitations or the conclusions, the strength of the conclusions that would differ. And then determination of the statistical analysis that will be performed. And we'll go through each of these briefly. Everyone's familiar with the different types of samples that we can take. Systematic samples and stratified samples. So systematic sample, we really discourage you using that because of the name systematic. There is some systematic selection of subjects which could distort your results. A stratified sample could be a randomized sample, but you're splitting your population into subgroups, and then you're randomly selecting from within the subgroups. And the reason we tend to do that is because we want to make sure that we have a more accurate view of the larger population as a whole. The best, though, is a sample that is chosen randomly, which basically says there's not a characteristic or a particular type of subject or person in the population that has a greater chance of being selected than another. So that's the issue with the VA study, right? If we were trying to generalize results from the VA to the greater population, what we're really saying is, well, that wasn't a random sample for our population, because people who walk into a VA hospital to be treated are different from the people in the greater population. So men of a certain age have a higher chance of being selected from the population than, for instance, young females or old females for that matter. So that would not be a random sample if I were trying to generalize my results to the larger population. Why do we care about randomness, though? Why do we want random samples? It's optimal. It's not always feasible, but it is optimal to have a random sample. And it's really for the reason I just stated, because you don't want those confounding or lurking variables that could be potentially associated with our outcome to distort our results when we're trying to generalize them to a population that doesn't look like our sample. If we do randomization, So for instance, what we very often take in clinical studies is what we call a convenience sample. It's just subjects or patients who walk into our clinic who meet the criteria for our study and agree to be on the study. So that's not really random. But then we exert some control over it by randomly assigning them to one of two treatments, for instance. What that randomization theoretically does is distributes all possible sources of nuisance variation or lurking variables equally across all of your treatment groups, and it essentially minimizes or eliminates their effect. It minimizes the chances of bias. And that's really the fundamental rule of using data inference. So if you're going to use inference in its truest form, you have to utilize random sampling or random assignment. Again, the purpose is to remove nuisance variables from the equation. If you randomly assign subjects to treatment levels, then you're ensuring that the groups that you're comparing differ only by the treatment. So remember that table 1, baseline characteristics? If randomization worked, then the baseline characteristics of your treatment groups should be similar. There's a huge caution that that process has a tendency to break down, basically not work, if you're doing a small study. So, take a step back. 5-10 minutes ago, what did we talk about? All these small studies in the literature, even if they're randomized controlled studies, if they're small, randomization may not have worked. There may still be problems with lurking variables. Did you have a question? Mm-hmm.
That are, in theory, already a homogeneous
Correct.
distribution. What is your opinion on the importance of randomization in those types of studies?
Is it feasible?
Well, in theory, it shouldn't be important, right, because they're all the same.
In theory, yeah.
Treatments that have to minus no treatments.
Yeah. Yeah. Well, I mean, you have so much more control over that scenario anyway, right? Because you don't have, they're all almost genetically, in animal studies, they're really the same genetic background. So you breed the animal to look a certain way, to have a certain genetic characteristic. So there's always a chance that there's some heterogeneity. Maybe one, let's say if you're doing a study in mice, there's one mouse that's just different. You don't know why. I would say if it's feasible, why not? But it's not as necessary as it would be in human study where we're very heterogeneous. Does that make sense? Yeah, people tend to not because you exert almost full control over the experimental situation. Yeah. Yes. Yes. Mm-hmm. Yeah, and that's a bias that randomization may not fix unless the instrument is associated specifically with the treatment group. So if you're only using an instrument for this crate and a different instrument for this crate, then the creep would be correlated with or associated with the outcome, would be associated with the treatment itself, right? So it would be confounding the treatment effect. Does that make sense? But if you're looking at longitudinal data, you're concerned about the effect of, if you're looking for an effect over time, but the instrument itself is changing over time, then your effect over time is confounded with your instrument. So, correct. Yeah, lots of different bias. And the types of bias that you have in an animal study could be the same kinds of bias that you have in a human study. I don't really focus on them as much, but it's really like what you just said, the creep over time of instruments, especially if you're doing something longitudinally. The randomization thing is typically not something that we think about when it comes to animal studies, unless especially ones that are genetically bred. They're bred to have a certain genetic profile. But you and I can speak after if you have any specific questions. So again, the things that we were just talking about, anything that can systematically distort your results in a particular direction, like changes in an instrumentation over time, or differences in instrumentation between groups, could result in bias and actually prevent you from getting a valid treatment effect. Nuisance variables don't have to operate in that way. They may just put noise into your data, and the result from that would be there's too much noise for you to detect anything meaningful, so you would end up with what we call a type 2 error or an underpowered study. And so this is where I refer you back to the workplace toxin and smoke exposure example from the first lecture. Here's a great animal example. Speaking of animal studies, you hypothesize that exposing albino rats to microwave radiation will decrease their food consumption. So when you're designing this study, there's a couple ways you could do it. You could do it as a yes-no exposure. So you would have some rats that would be exposed, some that would not be exposed. Or you could do it like in a dosing, where you go from no exposure, 0, all the way up to some maximum level of exposure to radiation. The outcome that you're measuring is the amount of food consumed. Let's assume it's a pre-post kind of thing. What are the possible nuisance variables? We just talked about a couple of issues that you could have with an animal study. Other nuisance variables, if you don't exert full control over the rat itself, could be the gender of the rat, the baseline or starting weight of the rat, the temperature of the cage, any previous feeding experiences. Are they all going to be in the same cage, or are they all in their own cages? Those kinds of things are potential sources of nuisance variation. Any others that you could think of? So the one that I can think of now that I didn't think of before this was if you're not measuring using the same instrument, or if you're measuring over time, that could be a potential source of nuisance variation. So the different types of data we collect in a clinical trial, and this is not specific to human studies. This could actually be an animal study as well. We tend to not worry about prognostic factors in the animal studies, though. You generally have your treatment, which is what we call the independent variable. The issue with treatment is that in human studies, we don't have full control over the subject's experience. So you have to make sure that you understand that the treatment that they were assigned to is not necessarily the treatment they actually receive. Has everyone heard of the concept of intent to treat? Yeah, and per protocol. There are different types of analyses that you could do. I'm not going to get into that today. We'll talk about that later on. But depending on how much difference exists between actual treatment assignment and actual treatment received, you could get very different conclusions depending on which type of analysis you performed. And there are benefits to one and benefits to both and negatives to both. The response, obviously, whatever outcome measure or measures that you choose to measure the patient's response to treatment, including negative effects, side effects to treatment if you're doing, for instance, a drug or a dose study. And then other covariates, which we call prognostic factors. So anything else about a subject's initial condition, background, history, whatever, that could possibly be associated with their outcome or affect their outcome. So these tend to be nuisance variables. Nuisance variables that you don't necessarily care about, but you know and acknowledge that they're going to have an impact on your outcome. So you make sure you record them. The 3 different types of outcome data, we talked about this last time. I'm going to come a little bit down on the amount of detail that I had last time, though, and just talk about them in terms of qualitative and quantitative. because analytically, we tend to treat them about the same. So qualitative, if you'll remember last time from levels of measurement, we have nominal and ordinal data. Nominal, if you'll remember, is something like gender, provides the least amount of information in a number. So if gender for subject A is 1, gender for subject B is 2, all the 1 and 2 are telling me is that they're different. Not that 2 is one more unit better than 1, for instance. Ordinal is also considered qualitative. Success, failure types of outcomes, stage or grade of disease. Quantitative measurements that we tend to record would be the interval or ratio data that we talked about, so the actual continuous measurements. So some kind of raw score like blood pressure or some kind of serum measurement, some difference, a ratio, a percent. And then a very unique kind of data, which we call time to event, which it turns out is both qualitative and quantitative. Why is it both? If you understand time to event data, there is an event, so an event either occurred or it didn't, so that's qualitative, and there's the length of time from some starting point until that event occurred. That's quantitative. And it's all wrapped up in one value. And we do a single analysis on that, which we usually call survival analysis. But the event does not have to be death. It can be disease progression or any number of things. So we tend to treat that data with a specific set of tools that don't fall into the qualitative or quantitative types. So when we're going through, we need to also specify the number of subjects required. How do we do that? At the end of the lecture today, I've got several slides going over an example of a sample size calculation for a t-test. I could spend an entire semester going over how to power studies. Just understand that the sample size is related to the design that you choose, the outcome, and, well, the hypothesis, which then determines which, together with the design and the outcome, determine what type of statistical test you're going to use. So every statistical test has some kind of mathematical theory underneath it. And there are typically, from the most basic types of analyses, some kind of formula that relates the power of the study, the type 1 error of the study, the sample size, and then the magnitude of the effect that you're wanting to see. So if you specify the magnitude of the effect that you want to see and the power that you need and the type 1 error rate, it'll spit out a number for you. And that's the number of subjects that you need for those assumptions. Very often, though, those are just assumptions. We really don't know if we're going to be able to see that particular size of effect that we have specified in the power calculation. So you have to be wary when you do power calculation to understand that the sample size that you get is also an estimate. It may be too big or too small, depending on what your data ends up looking like. You have to specify the procedure for assigning subjects, which we've talked about, and then determine the analysis that will be performed. Some considerations when you choose, when you specify some of these things, you have to make sure that whatever you're doing gives you a valid estimate of a treatment effect. So what do I mean by valid? I mean what you're measuring is actually what you think you're measuring. You're not measuring the effect of something else on your outcome. Or the example that I had before where it was at county level was what they were really asked, and that was what their research question was, but they were not able to get a valid estimate of the county level need for something that was actually at the level of the county manager. Does the data collection procedure produce reliable results? What do I mean by that? Meaning, are my measurement tools actually accurately measuring what I think they're measuring? How is the data getting into the database? What database are you using? What are the chances of getting a value in there that is not accurate? So you meant to put in a 10, but you accidentally hit 0 twice and you got a 100, which would have a very different meaning depending on what scale it was on. So you have to be careful that you have systems in place that the data is measured accurately and recorded accurately. Does the design possess sufficient power to permit an adequate test of the hypothesis? So is your sample size essentially large enough? Now, there's a lot of issues around power calculation that I'd like to address. Hopefully we'll get to them. But the primary thing is you have to know what you're looking for, not what you think you're going to find. So what you're looking for, if you're using a particular measurement or instrument tool where in the literature it's been published that a 10% increase is the minimum increase that would be clinically meaningful, then you should power your study for that clinically meaningful difference. Maybe something a little bit smaller just in case you have more noise in your outcome. So understanding that what you're powering for is not what you think you'll find, but what you should find. Anything smaller than that, you don't care about. Anything bigger than that, you will be powered to detect. Very often, we don't know what that clinically meaningful difference is, which is why we have pilot studies, to estimate what this outcome looks like under these particular conditions and what we think clinically meaningful would mean for a particular scale. Also important, does your experimental procedure conform to the accepted practices and procedures used in the research area? Why do we care about that? Well, we want to be able to compare our findings with the results of other investigations. So, if you're considering a different type of outcome for measuring disease progression than is what's being reported in the literature or being supported by a particular, like NCI says, this is how I want you to measure side effects and grade them. Different organizations said this is how I want you to measure disease progression using these particular parameters. If you're not conforming to that, then you'll have a very difficult time seeing how your findings align with the results of other investigations who do conform to that. Doesn't mean you can't use other outcomes. You can, but you should also be collecting the measurements that are being reported in the literature. We briefly talked about this last time. I'm about to get into the types of studies, the types of designs that you could use. I want to emphasize here again that depending on the purpose of your research and the strategy that you choose, there's a trade-off between ambiguity in the results and control that you have over the experimental situation. There's also generalizability in here as well, because it turns out the more control you exert over your experiment, the less generalizable it is to reality. That's very often one of the issues linking animal studies and why they can't necessarily translate into humans. Because we go from almost 100% control to very little real control in humans. You saw this last time as well. Studies can be broken down into descriptive, where we're really just trying to describe something, versus analytic, where we're actually doing analyses. I'm actually doing hypothesis testing. Pilot studies could be either, but generally you want to start with descriptive studies if nothing's ever been done in your area or in the specific situation that you're investigating, because you don't know how to power a study if you don't have any information, any prior information about what the outcome looks like in your population. So again, descriptive, analytic. An analytic can be dropped down into observational versus experimental. Why does that matter? Observation versus experimental. Analytically, doesn't really make that much of a difference. If it's a one-way analysis of variance, it's going to be a one-way ANOVA regardless of whether the conditions were observed, like in an observational study, or whether they were assigned. Where that makes an impact is the interpretation of the results of the ANOVA that you use to analyze the data. So what are cross-sectional studies? Let's go back again. I'm starting over here on the left. Cross-sectional studies, observational. They're designed to assess the association between an exposure and a disease. We can say independent variable here because it turns out it could be what we call a treatment or other classification. The selection of the study subjects is based both on their exposure status and their outcome status. So we really don't know, since we're looking at a single point in time, whether the outcome occurred first or the exposure occurred first. So if you think about looking at the relationship between a disease and an exposure, they come to you with both, but you don't have any way of knowing for certain if the exposure was before or after the disease showed itself. So there really is no direction of inquiry for a cross-sectional study. So there's no time component, no temporal component. You define your population, you gather information for subjects on their exposure and their disease status, and then you classify them into groups. You'll have some subjects who are both exposed and diseased. You'll have some that were non-exposed and also not diseased. The reason I'm emphasizing that there's no time relationship is because that's part of the limitations of a cross-sectional study. Cross-sectional studies cannot determine cause and effect. Why? Because they're observational, right? And they can't determine any temporal relationship between exposure and outcome. Why? Because they're cross-sectional. They're at a single point in time. We don't know which occurred first, so we can't say X follows Y. So it's just looking at associations, and that's the appropriate statistical terminology, that X or disease is associated with exposure or it's correlated with exposure. We don't say with these types of study that exposure to treatment causes a response or exposure to toxin causes disease. We also don't say that anything follows anything else. That's a limitation of this type of study. Cross-sectional data, very often when you're looking at the association between an exposure and a disease or a treatment and an outcome, you look at things in terms of prevalence or risks, odds ratio, because you have what's called contingency table data. You've classified your subjects into one of 4 groups, and then you look at, for instance, the prevalence of disease, comparing exposed versus non-exposed groups. You could also look at the prevalence of exposure compared in diseased versus non-diseased groups. And I've given you some simple formulas here, but again, this is a very simplistic view of cross-sectional data. Case control studies are only different from cross-sectional studies in that they tend to have a time component. And it turns out these are what are called retrospective studies. Why are they retrospective? Because we assess the association between a current disease, a subject comes in, they have a disease or they don't, and then you look back in time to see whether or not they actually had the exposure of interest. So notice the time component on the x-axis now. We define our population here. We gather information on whether or not they have the disease or the outcome of interest. And then using self-reported measures or charts, medical charts, we look back in time to determine whether or not they were exposed or unexposed. So an easy example of this is lung cancer. You have individuals who have lung cancer and don't. Then we go back in time, or we ask them, do you smoke? Did you smoke? When did you start smoking? When did you stop smoking? That kind of thing, to see whether they were exposed. And then we can then identify whether there's an association or a correlation between smoking and lung cancer. But we don't show cause and effect with this kind of study. Looks very similar in terms of the type of data. It's a contingency table, that's what we call it. Whenever we have classification, subjects can fall into one of two levels of two different types of outcomes of interest. And we very often talk about odds. Odds of exposure for people who actually have the disease, which we call cases, and then odds of exposure for people who were healthy, which we call the controls. And very often we choose the controls to look a lot like our cases. Why do we do that? What are we trying to do? Minimize bias. What would cause bias if we didn't choose controls who looked like our cases? We would have two groups. We're comparing cases and controls. If they have other things that could be associated with the disease, like other lifestyle behaviors besides smoking, that could result in whatever disease we're looking at, that could be the problem causing the disease, not the exposure of interest. So we kind of match them together, right, based on other confounding factors, anything that could be possibly associated with the outcome of interest.
I'm sure there must be practical reasons why you would do cross-sectional versus case control.
Usually it's feasibility.
Sometimes you can't determine the temporal relationship.
Correct. So a lot of times whenever I see people doing like a cross-sectional study, it's because they have limited resources to really fully investigate. And usually, if we think about it in terms of the scientific process, it's very early on. So there's a feasibility issue. Maybe they just don't have the time or the resources or the ability. Very often in exposure and disease types of studies, if you don't do a cross-sectional study or a retrospective study, what do you have to do? Follow them for a long time, right? And hope that some of them eventually get the disease of interest. Not hope, that's a terrible term to... Well, in a cross-sectional study, what you have is people who come in and you know right away that they had the exposure and the disease, but you don't have the information about when the exposure occurred or when the disease started. And I would even argue that in registry data, we don't have a lot of that information. I've dealt with a lot of the data sources that we collect, and very often, once you really get into the data, sometimes the dates don't make sense, so it's not clear if this is a diagnosis date or if it's for the disease that you're actually looking at, maybe a different type of cancer. There's lots of issues, lots of reasons why you would do a cross-sectional study, and very often it's a limitation of what you have available to you. It is stronger evidence if you're trying to show a temporal relationship. That's the only benefit, is that you know that the exposure was before the disease, or the effect or the independent variable was before the outcome. Cohort studies, and I always get this mixed up too, so all the terminology that we use. Cohort studies are designed to assess the association, just like in the others, between an independent variable, which is usually an exposure to something, whether it be a treatment or a toxin or whatever, and a disease occurrence or some kind of outcome. It could be death, for instance. The selection of the study subjects is based on their exposure status, and the direction of inquiry is forward. So a cohort study is just an observational study. That's what I typically think of when I think of a cohort study. I'm looking at subjects who exercise regularly versus subjects who don't. So their exposure in this case is their self-selected choice of exercise. And then I follow them forward to find out whether or not they differ in terms of an outcome of interest. So maybe it's 5-year survival, 10-year survival, any kind of outcome that I could be interested in. This is the direction of inquiry in this kind of study is forward. So this is what's called a prospective study, whereas this was a retrospective study. Now, there are benefits to prospective studies that we don't have in retrospective studies. What's the biggest issue with retrospective data? Bias, yeah. What kind of bias, though? All kinds of bias. That's a very good, yeah, there's lots of bias, right? So if you're asking the patient to recall whether or not they even had the exposure, you're going to get measurement error there, right? Because I can speak for myself. I can't remember sometimes 2 days ago, let alone 6 years ago, 10 years ago, accurately. So self-report is notoriously problematic because you're going to get error in your measurement. What else is wrong with looking back in time? Outside of the context of just this particular example. If I look back in time, what if I'm looking back 15 years or 20 years? What could cause things to change, an outcome to change? Your population changes. Your population could change. It could age. So you could artificially be seeing more something occurring just because the population is older now than it used to be. Treatment changes. So this is not necessarily the problem with a case control study, but if you're looking at comparing the results of your pilot study to what we call a historical control, you got to be very careful. That's one of the problems. They're useful, but that's one of the problems with historical controls is that the population is different. The degree of difference may be small, but it could be very large depending on how far back you have to go. Treatments could have changed. Lots of things could change over time. So,
Sorry. So this with the time along the bottom there, it looks like the study starts where that vertical line is. So
it does.
Are you not allowed to know what their disease status is when you start your study? You have to wait.
No, you define your subjects and by your population, number one, by their disease. Number two, you gather your subjects based on their disease, and then you select your controls to be as similar to your diseased subjects as possible. So very often you'll hear about a matched case control. So if I have, a man who's 65, who's here for lung cancer, who smoked, then I would want to get someone that's as similar to him, but without knowing necessarily their exposure, but they don't have lung cancer. That would be the matched control. So again, this is a prospective longitudinal study. We talked about the benefit of this is that when you see something in real time, the chances are higher that you're actually going to measure it accurately. You don't have the issues with like retrospective recall and things like that, recall bias. What's the problem, though, with longitudinal studies? They could take a very long time. They cost a lot of money. Whenever I ask a subject to come back every 6 months for 5 years, or I try to phone them every 6 months for 5 years, what's an issue? Compliance, dropout, lost follow-up. So no study's perfect, right? All of them have their issues. You just have to balance what's feasible with what's optimal. So again, issues with cohort studies, loss to follow-up or attrition, time and money. They're very inefficient if what you're studying is what's called a rare disease. Why? Because if you fall, yeah, exactly. The disease may not happen. I mean, and if you're familiar with statistics enough, you'll understand that when you look at rates of disease in longitudinal studies, if you're doing like a survival analysis, sample size is not the only thing that is important when you're computing your power. It's also how large of a number of these subjects do I expect to eventually get the disease or to eventually die or eventually progress. The event rate is huge. It makes a huge impact on the size your study needs to be. So if you have an event rate that's very small, you may need to have more subjects than are available. And I'm talking thousands and thousands and thousands of subjects. So the biases that we could have here, we talked about the other biases in other studies. Non-response bias is probably the most familiar for longitudinal studies. How would we analyze cohort data? Looks exactly the same. Now again, what are we assuming about all of these? We're assuming that the outcome is a category. When we have categorical outcomes, we tend to end up with what are called contingency tables. It's possible in studies like this, your outcome will not be categorical. I didn't go into that for the sake of time, and so I would be able to just demonstrate to you the different types of studies without bogging you down in the details of analysis, which we'll get to later. So again, if you have cohort data, here's another term, relative risk. We had odds ratio, we had prevalence, incidence. Those are terms that are commonly associated with these types of studies. The relative risk is just the risk of disease occurring in the exposed subjects over the risk of disease in the unexposed subjects. So if you get a relative risk of 1, then that means that the risk is the same. If I get something that's greater than 1, then the risk is higher for those that are exposed and lower in those that are unexposed. So that would indicate to me that there's an association between exposure and the disease. A historical control would not show, these studies are studies that have 2 treatment groups. So a historical control generally is whenever you have a single group where you're testing, let's say you have a drug, a drug that you think is going to work. You want to test and see if it works, but you don't have enough resources to have a randomized study. So what you do is you put all of your subjects into the treatment group, and then you use as a control group a reported rate from other studies in a similar. It doesn't really fit in here. No, it's another bias issue. But I wanted to bring it up when we talked about retrospective and stuff like that, because that is part of a retrospective issue. Randomized controlled trials. These are the gold standard for testing for a treatment effect. They are designed to test the association between some exposure, whether it be to a toxin or to a treatment, and an eventual outcome, whether it be a disease or a resolution of disease or a prevention of a disease. Selection of study subjects is based on their assigned exposure status, and then you follow them prospectively. So the biggest difference here between the randomized controlled trial and what I called a cohort or observational study before is what? That right there, the randomization. And the reason we randomize is, number one, because it's feasible, it's optimal, it minimizes the impact of nuisance variables, minimizes the potential for bias from them. So you randomize them, I call it, just to say to stay in the same realm here, randomize them to exposure. They're either treated with the therapy of interest or they're not. So they're either exposed or they're not exposed to the treatment of interest. And then you follow them forward in time and record their outcome. In this case, the outcome is a yes-no. It could be that they get a disease or they don't. The disease resolves or it doesn't. They respond to treatment. Their disease responds to treatment. Maybe they're not cured, but they respond to it. It could be death. Yes, no. And again, why do we randomize? Why do we do anything in design of experiments? To minimize bias, to get a valid estimate of a treatment effect. Suppose we wish to compare surgery to a drug. So we have two different treatments here. A drug used to treat a disease and surgery used to treat a disease. We know that major heart surgery is invasive and complex. Some people die because of the treatment itself, the surgery. This is also a very common issue in cancer studies because people can die from the treatment rather than the disease. We may assign patients with less severe disease, either on purpose or not, to the surgery group. So if we see a difference in patient survival, is it due to the surgery versus drug aspect, or is it due to the severity of disease aspect? This is very similar to the observational study that I showed you with the workplace toxin. What we end up having is subjects who are in the surgery group also have less severe disease. And both of those characteristics affect our outcome, which is essentially survival. Less severe disease impacts survival. Surgery could impact survival. And it turns out if we did this by not using random assignment, we would end up with subjects in the drug group who had more complex disease or more serious disease. So we have what's called confounding here between the severity of the disease and the treatment, and there's no way, even with statistical models or adjusting, that you could get to whether it's the surgery versus drug effect or the disease effect that's causing the outcome to differ. So unfortunately, when you don't utilize randomization, if you're systematically placing patients into treatment groups based on their baseline characteristics, you are influencing the outcome, biasing the outcome, and it would be a total waste of time, total waste of money, and a total waste of patient resources. Does everyone understand why that would be an issue? Does everyone see how, if I were to randomize, just totally remove any knowledge about assignment in the actual assignment process, that would help eliminate some of the issue we have here with the confounding or nuisance variables? We randomize also because there's really no way for you to understand or be aware of all possible things that could influence your outcome. So randomization in a moderate to large study will work very well in removing those sources of bias. The problem with observational studies, analytically you can treat them the same, but when you conclude from them, whatever their evidence states, it's actually more ambiguous. There's more ambiguity in the conclusions because you don't have any formal control over confounding variables. What else do we do to protect against bias? Is everyone familiar with the term blinding? Blinding is just removing knowledge of treatment assignment from different people who have an impact on the outcome. So you could have a single blind, which removes the knowledge from the patient being treated. You could do a double blind, which removes the knowledge from both the patient and the person evaluating the patient's response to treatment. Or you could even do triple blind, where the statistician is blinded to treatment assignment as well. And if we think about removing the knowledge from each of these different people in a study, we can intuitively understand what we're doing, right? If a patient knows they're being treated with a particular drug, or if a patient knows they're being treated with a placebo, we have an issue there, right? Because they could become discouraged. They could drop out of the study if they don't like their assignment. And then we have higher attrition, which is associated with a particular treatment. We have what's called the placebo effect, which we control for a little bit in the control groups. But you can think about that in the blinding as well. So if a subject doesn't know they're being treated, then their own biases about whether or not this treatment's going to work are removed from the situation. So if I'm going into a clinical study as a patient and I get this treatment that I've heard lots of great things about and I was hoping I would get that one and not the other one, then I may, just because of my excitement or my own preconceived notions about how effective this drug is going to be, I may actually report that I feel better. So that could be an issue. That's what blinding does for the patient. For the evaluator, it's the same thing. The evaluator, it removes their own inherent biases about whether or not they think a treatment is going to work better or not from the evaluation. As a statistician, I like it when the data is blinded to me, meaning I'll get the data and the treatment assignment will say 1 or 2. It won't say experimental and control. Why do I like it that way? Because then I don't have to worry about if I'm giving the investigator a positive result or not. I'm analyzing the data according to my plan, all my own biases about how I want this to be successful or removed. And I generate the results and give it to the PI, and then we move forward. And it's only after the analysis is done that we unblind whether or not the treatment was better than, for instance, the control. Why do we use control groups? There are lots of different types of control groups. There's what's called a null control, a placebo control, and an active control. And they all three do different things. There are some cases where you would never use a null control or a placebo control. Can someone give me an idea of when you would never want to give a patient a placebo? Exactly. If there's a standard treatment already available, it's very difficult to justify using a placebo. Because what you're basically doing is you're not giving them the standard of care. That's an ethical problem. So only when we're doing things, you could think of it like if you're testing a treatment for headaches, it's easily justifiable there to see whether or not something is better than a placebo in that case. The different biases that arise that you're controlling for in a null control where you have a group that's randomly assigned to get no treatment. What that's measuring in that group is the natural progression of the disease. So if I were to follow subjects long enough, would the disease resolve itself without any treatment? If I didn't look at a null control, then what I may be seeing is a natural resolution of disease, and I'm attributing part of that to the treatment. So I can control for that or pull that effect out with a null group. The placebo group measures the placebo effect, which is simply responding because you're being treated by something, when there's no active drug, for instance, in the pill that you're using. I'm going to skip. When you're doing an analysis for randomized controlled trial data, you have to ask yourself, again, I've only showed really sort of binary categorical outcomes. You may have continuous outcomes. In that case, the analysis that I showed you, the contingency table data, is not going to be accurate. You may also have more samples or groups than just 2. It could be that you have a placebo group, a treatment A, and a treatment B. In that case, again, it would look a little bit different. Another thing that you have to take into account is whether or not your groups are related or are they independent. So a good example of groups that are related in a randomized controlled trial is what we call a crossover study. Does Has everyone heard of a crossover study? A crossover study is where you randomly assign subjects to treatment A or treatment B. They get the treatment, you record the outcome, then you wait a little while, and then you cross them over to the other treatment. So they're essentially serving as their own control. But there are issues with that. But not recognizing that there is some dependence in those samples, meaning it's the same subject in treatment A and treatment B, could cause you some issues with your analysis. We'll talk about crossover studies in Lecture 4. I wanted to throw this in here somewhere because we've had questions about it in the past, the different types of tests that you could use from your clinical trial data. What you're most familiar with are what are called parametric methods. Parametric methods make assumptions. So probably a method that's very familiar to most of you is the t-test. Does anyone know what the assumptions of the t-test are? I heard somebody say something correct. Yeah, so your data looks like a bell curve, right? The outcome that you're analyzing looks like a bell curve, a nice normal distribution, or it's symmetric. If you have a two-sample t-test, it also assumes that in your two different groups that the variability in your outcome is approximately the same. If you don't have that, then the t-test will it'll still work, it'll still run, it'll still give you a number, but it won't be the number that you think you're getting. It won't be a test of whether or not the means are different. It will be something else, but we don't know what it is. So it increases the chances of you getting an incorrect result when you use a method, but you don't meet the assumptions of that method. And that's true for any parametric method. They're generally suitable for large sample sizes. And why do we need large sample sizes? We need them large enough that we can actually test whether or not we have normality in our data. We can actually test whether or not we have equal variances. If we have really small samples, we could probably visualize the data, but it wouldn't be clear if we met the assumptions or not. So we don't want to use parametrics for small data, small samples, or in situations where we can't meet the assumptions. And I will cover in a talk either next week or the week after, what do we do if we don't meet the assumptions? But we still want to use a parametric method. We may transform the data using some different techniques, and we'll go through some examples of that. Another alternative, if you have small sample sizes or your data don't meet the assumptions of your method, is to use what's called a non-parametric method. A non-parametric method makes no assumptions about normal distributions or equal variances or sample size or any of that. It's actually the really flexible, useful tools. So if that's the case, why don't we use them more often? They're not quite as sensitive, meaning a t-test versus what we call a Wilcoxon test. The t-test is much, much more powerful for detecting an effect than the Wilcoxon test would be if your data met the assumptions of the t-test. So if you can verify that you've got the assumptions met, use the parametric method. It's more sensitive. But if you can't, to be conservative, you should use a non-parametric method because you know the result you're getting is a valid result as opposed to a function of skewed data or very large variance in one group as opposed to the next. Non-parametric methods in general, what they do is they strip the value from the data and they use the rank. They just order them and rank them, and then they analyze the ranks of the data as opposed to the actual data themselves. So again, the trade-off is a loss of power if you use non-parametric methods instead of parametric when you should have used parametric methods. Some of the most commonly used tests, if you have two groups, so again, I'm going back to the randomized controlled trial example. Before we talked about a yes-no outcome. They either responded or they didn't. If that's the case, then you have what's called a binary outcome, and you would probably report the percentage or proportion of subjects who responded in the different treatment groups, and then you would use something like a Fisher's exact test. A Fisher's exact test is good for contingency table data, like we've seen in any of those studies, and it's a non-parametric method. So it doesn't matter if you've got a large number of observations or not. You could also use a chi-square test. A chi-square test is essentially testing to see whether or not the proportion of subjects that responded in the two groups is the same, or is it different? Is it higher, for instance, in the treatment group? The chi-square test has a parametric assumption. You call it that. It's actually a sample size restriction, so you have to have a certain sample size before you can use it. Two independent means. So in the randomized controlled trial data, from this example here, suppose that this outcome was not a disease, but suppose that we were measuring for people who were treated their total cholesterol after a drug was administered for 6 months. The total cholesterol would then be a continuous outcome, and I wouldn't necessarily have categories to look at. So what would I do in that case? I would probably compare their mean, the mean serum total cholesterol in the treated versus the untreated, and I could test whether those means are the same using the two-sample t-test. I could do ANOVA, which is just like a two-sample t-test when I have two groups. Or I could do a non-parametric Mann-Whitney, Wilcoxon-Mann-Whitney, it has a variety of different names, test, which is essentially a rank-based test. It is non-parametric. If I have a small sample, I would probably defer to the Mann-Whitney test. If I had horrible issues with my variances or my normality that I couldn't fix using transformations, I would use the Mann-Whitney test. What if I had that, we talked about that unique type of data, which is time to event, which is both a yes-no and a continuous outcome. That has its own set of methods, which we call survival methods. A test to see whether or not the time to event differs between two groups could be done using a log rank test. And the log rank test is a non-parametric method. Suppose, though, when I'm doing my analysis, when I'm comparing the response rates between groups or comparing the average responses between groups, that there's something else I need to adjust or account for in my analysis. That's when regression methods become very useful. So I can do regression, and I'm still testing whether or not there's a treatment difference in terms of the yes-no outcome or a treatment difference in terms of the continuous outcome. But now I'm adjusting for further prognostic factors, for instance. So in addition to the non-parametric method, which I've bolded, and the parametric methods, which I've listed, I've given you the name of the type of regression that's used for that data. Logistic regression is a regression that's used when you have a yes-no outcome. There's something called ordinal logistic regression when you have ordered categories. Linear regression is probably what you're most familiar with. That's when you have a continuous outcome. And then in time to event outcomes, we use what's called Cox regression. And all regression models do is allow you to account for other factors or variables when you're doing the comparison. I'm going to skip. Well, we can briefly talk about this. We're almost out of time. I want to make sure that I get to the power. Threats to valid inference, we've already talked about many of these, so I'm just going to reiterate. You could have low power, which means that you would fail to find something when it's really there. That could be for many different reasons. You have too much noise in your data, or your study is too small. You could have violated assumptions of the test. So I said a moment ago The t-test requires normality and equal variances if you have that two-sample t-test. If you don't check those, then that test statistic and that p-value that you get out, they're testing something, but they're not testing what you think they're testing. So you could actually get a result that looks like a result that's not testing the hypothesis that you think, if you don't check the assumptions and make sure you're not violating them. And the reason that the violated assumptions could cause such an issue is because there's mathematics underlying that test. And in order to make the mathematics work, the person that derived the t said, I have to assume the data look like this before this method will give a result that's testing this particular hypothesis. We've talked about this as well, the reliability of the actual outcomes that you're using, the measurement instruments that you're using, your ability to make sure that the treatment is being administered or implemented the same way for all subjects. Internal validity could be at risk when you have any events other than treatment that occur between the time treatment is assigned and the time the outcome is measured. So the subject could be diagnosed with a different disease, for instance. That would be an uncontrolled event that you would need to have knowledge of because it could affect the eventual outcome of for your particular study. And then the passing of time. So any process is not related to treatment that simply occur as a function of time may affect the outcome. These all cause bias. They threaten the validity of your inference. We talked about instrumentation issues. We talked about subjective criteria used by observers. We talked about when subjects receive what they perceive as a less desirable treatment, what happens. We talked about the placebo effect. Generalizability, we've only touched on this. We have to be careful about how our results are generalized to a larger population. That's what's called external validity, and there are threats to that. For instance, one of the biggest problems with generalizability of clinical research is the fact that we do have control over the treatment. And we talked about this last week when we talked about the type or the strength of evidence. In a clinical setting, if you have full control over the intervention, meaning you administer it in an exact way, then that won't necessarily generalize to reality when the parameters of how it's actually being done or administered could change or vary. And that would definitely affect how effective it was. So think about that when you talk about generalizability. That's external validity. One of the biggest problems that could affect generalizability would be self-selection. So this is a problem for observational studies. People self-select to certain behaviors. And there will be certain behaviors of interest that you're following and other behaviors that could be associated that are also negative that could be causing the outcome and not necessarily the one that you're testing. The interaction of setting and treatment, that's what I was just mentioning, where your results that you obtain in a clinical setting may not generalize to the outside world. Okay, we've got about 20 minutes to talk about study size. The size of your study is directly related to your goal, right? So if you have a pretty ambitious goal, then you better have a lot of resources at your disposal so you can do a large study. Very often, though, in the scientific process, we have to start somewhere. And I do encourage, even though it sounded like at the beginning I didn't, I do encourage understanding where the science is. If the science is not very far along, you should not be doing a very large randomized controlled study. You should not have very rigorous type 1 and type 2 error rates. What you need to be doing is a pilot study to get an idea about what could be going on, to give you a picture about what your outcome looks like under the type of conditions that you're thinking of exploring in a bigger study. So in terms of clinical studies, and this is unfortunately geared more toward pharmaceutical therapy, drug therapy, but it can be true in other investigations. You have preclinical stuff that goes on in animals or in vivo or in vitro, where you're looking at cells or tissues in the dish or animals to get a preliminary idea of what this would look like if I took it into a human. Then you have what are called phase 0 studies, which are the exploratory studies. You just want to establish what is going on, get an idea of whether or not the effect that you think is happening is actually there. Is there any evidence? And it's typically a very small study. So if you're very early on in the science, what you would call a phase 0 study in a pharmaceutical clinical trial really is for any area of research. It's a pilot study, small, and then it just allows you to say, yes, I want to move forward with this area of investigation, or no, I need to change paths because this is not really working out the way that I think it is. If you use only 10 to 15 subjects, then you minimize exposure of patients to possibly harmful treatment, and you also minimize the cost associated with kind of following a red herring, for instance. You don't go right full on into a very large study. Phase 1 studies are a little bit bigger. They're a little bit more ambitious. They're looking at how safe the drug is. Is it feasible? Is it tolerable? Also looking at, if it's a drug study, the PK of the type of the drug. And it's, again, 20 subjects. It can go as high as 80 that's typically more non-academic medical center sample size. A phase 2 study assesses the efficacy and continues to assess safety. Phase 2 studies can be a small, single treatment group, but we would prefer that there be randomization involved. It would still be a small, randomized study to begin to assess how effective something is and how safe it is. But it's not the definitive evidence. The definitive evidence comes into a larger study where you've got definitive evidence that you can use to help power this larger, randomized, controlled trial. This, what the clinical trials realm calls a phase 3 study, is really that gold standard where you have blinding in place, you have adequate controls in place, you have a large enough sample size that you get a very good grasp on whether or not this thing is actually safe and does it work. And you have really strict error rates. So alpha is 0.05, maybe even 0.01, and your power is 80% or better. These cost a lot of money, though, so you don't start here. You generally end up here. Phase 4 studies are very important anytime anything goes into reality, right? When it goes out into the population, now we've removed the absolute control over the intervention. How does it perform when it's actually out functioning in reality? So you can think about this. If you're creating a new way of getting people to manage their disease, this is not a drug study. This is me investigating whether or not this new management or this new set of management skills works for a particular type of patient, and I implement it in a study where I have total control over how it's administered, and I meet with the patients over and over, and it's a really intensive thing, and then I publish it, and people take that and say, wow, look how well this has worked. And then they go and do it, but they don't do it exactly how you did it. Then it may fail once it gets out in what we call phase 4, post-marketing. Lasagna's law, I always like to put this in here because it really talks about our expectations of what we have available versus what reality tends to be. We always think, oh, I can get 100 patients like that. And you struggle to get 15. And that's a very common problem. So again, I mentioned last Friday and briefly this morning, one of the biggest questions I get is how many subjects or patients do I need? The first question that you really need to ask yourself is, how many can I get? That's a feasibility issue. And then once the statistician knows how many you can get, then we talk about what the design of the study is, what the outcome is, what's an appropriate test, and then I can tell, as a statistician, what a required sample size would be for your assumptions. In general, what we're aiming for is the minimum number of patients required to achieve our principal scientific objective. Now, there could be different objectives. Notice I didn't call this power. I just said, what's my sample size? Because not every study needs to be powered. You may have studies where you have a single group, a pilot study. Power, in that case, may not make sense if you're not actually doing statistical inference. You may be more interested in just estimating things that are going on. So estimation trials use interval estimates like confidence intervals to describe the outcome of interest. It could be for a single group or multiple groups. And the sample size is justified based on how precise your estimates will end up being, given a certain set of assumptions. Power calculations only occur when you're really doing hypothesis testing, when you're trying to detect a difference between treatments or some kind of a strength of association. We talked last time about the type 1 and type 2 error rates. So the type 1 error rate alpha, we generally set at 0.05. I encourage you, if you weren't here, go back to lecture 1 and listen to the part where we talked about when alpha shouldn't be 0.05, because there are certain circumstances. The type 2 error rate, beta, is a different type of error. It's actually 1 minus the power. So you can talk about power here. It's generally what we talk about, not beta. So the type 1 error rate talks about how often, what is the risk of concluding there's a difference in treatments when in fact there's not. And the type 2 error rate says, what's the risk of concluding that there is no difference when there actually is. And that's what's called being underpowered, or having a type 2 error rate that's too big. So we generally want our error rates to be small and our power to be large. Some of the conventions are alpha is 0.05 and power, which is 1 minus beta, is about 0.8 or 80%. But those can vary depending on, again, what your goal is. If you set alpha, you set your power, and you talk about, or you tell the statistician what you're looking for, then they should have enough information, minus some other things that we may have to dig up, to get you an estimate of the number of subjects that would be required. If you're doing estimation would come along with a measure of precision. So you could say, with 25 subjects, I can estimate the response rate with a margin of error no greater than 10%, as opposed to being able to detect a 5-fold change with 80% power at the type 1 error rate of 0.05. So here's a brief example where we have a continuous outcome. This very often occurs whenever you're looking at a comparison of means between groups. Subjects were randomized. So this is a randomized controlled trial. And I'm recording the outcome. I'm going to call it W, just to be kind of generic here. But it could be something like HbA1c, where I think if I administer treatment A, HbA1c will increase. But I don't know if it's going to increase or decrease. I need to know if it's going to change it at all. So I'm going to do what's called a two-sided t-test. If you remember, the two-sided t-test does what? It picks up an evidence of an increase and a decrease in the p-value. If I did a directional hypothesis, a one-sided, it's possible that I would only be able to pick up the evidence in the p-value for one particular direction, and I could miss it for the other. So the analysis plan is I'm going to compare the mean response of patients on treatment A versus those on placebo. The mean response for treatment A I'm going to call mu1. Don't get bogged down in notation though, but just so you'll know for the next slides. Mu1 and mu2 is the mean response for people on placebo. And again, the outcome is like, for instance, HbA1c. The appropriate test for this would be a two-sided t-test. I'm going to use alpha 0.05 because that's the standard. How do I power this? Well, I have to figure out what I want to detect, right? What I'm really looking for is some kind of difference between these two means. But the question is, what's the smallest difference between the mean HbA1c for treatment A and the mean HbA1c for placebo that's interesting to me, to my colleagues, to my field? That's up to the PI or the investigator to determine. So what the investigator has said is that under placebo, I expect this outcome to be 10. That's in untreated subjects. I think I'm going to get a value of 10. In other words, mu2 is equal to 10. The difference that I want to detect that's clinically meaningful or interesting would be a 10% increase in response under treatment A. So whatever my response is under placebo, if I see a 10% change in that, then that's what I want to be able to detect with my study. How many subjects do I need to find that difference? So if I increase that response by 10%, 10% of 10 is just 1. This is a very simple example. So 11 is what I would expect for mu1, and anything more than 11 I will automatically be powered for, because that'll be a bigger signal, an even bigger signal. So how many subjects do I need to be 80% sure that I can detect this difference as statistically significant, or that if I have a difference of 1, as we've shown here, that my p-value will be smaller than 0.05 with 80% certainty? Does that make sense? That's all you're doing. So here's what we actually have from that. Our null hypothesis that we're testing is that the mean HbA1c, or the mean outcome in treatment A and placebo, is the same versus they're different. But I can't just know that they're different. I have to specifically state a difference before power will work. So this is a two-sided test. The difference between mu1 and mu2, I'm going to call delta, and that was just 1, remember, because one of these was 11, the other was 10. I don't care if it's an increase or a decrease. I just need to know that it's different by 1. I specified 5% for alpha, 80% for power. One of the ways to determine what difference would be clinically meaningful, if you don't have the ability to specify the exact values of these mean responses, would be what's called an effect size. Has everyone heard of an effect size? If you'll notice, D, which is a very common terminology for effect size, it's just the difference between the two means scaled by how variable your data is. And then there's a scale, so you can, I don't recall exactly what a small effect, a medium effect, and a large effect is, but this would allow you to get around specifying exact values of mu1, exact values of mu2, and it turns out, by the way, you also have to have an estimate of the variability in the data. That's what's called a nuisance parameter. We don't care about it, but we have to know it to compute the sample size. So Cohen's D for a two-sample t-test says if you want to detect a small effect, then D could be equal to I don't know if it's 0.2, let's say it's 0.2. And then I could plug that into the formula without having to specify mu1, mu2, or sigma. And very often we have to do that because we don't know what those values are going to be. Now here's the picture of the moment. Let's see if I can do a good job of explaining this. This is really mathematically what's happening underneath a two-sided t-test. What I have here, for a moment, let's ignore the dotted lines. Everyone focus on that nice normal distribution in the middle. That is my null distribution. And if you remember from last time I showed you, if we make an assumption about what our population looks like, that's a theory. So this theory is that our population looks like a normal distribution where the majority of subjects in this population have characteristics in this particular region. But if I get evidence from my sample, if I draw a sample from that population, if this theory is true, then the sample average response should be somewhere right in here, right? It should agree with this theory. That's why we call this the null region, and why we fail to reject that theory, because the evidence actually supports it. So hypothesis testing, again, is giving you a mechanism by which you can choose between competing theories. So the null theory that we hope to reject is the solid line. The alternative theory, though, which we didn't see on the last slide last time, are the dotted lines. My alternative theory, what did my alternative hypothesis say? Where'd it go? My alternative hypothesis says that there's a difference. Either I'm going to see an increase in HbA1c or I'm going to see a decrease in HbA1c, and I want to detect that. So notice, let's say that this is a zero difference. Then values around 0 would be in support of similar HbA1c levels in the two groups. So that's our null. But if I get values, if this x-axis is the difference in HbA1c for placebo and treatment, if I get far to the left of 0 or far to the right of 0, what am I doing? I'm getting evidence in my data that's more strongly in favor of my alternative hypothesis than it is of my null. It could still be generated by that null circumstance, but the chances of it coming from that null distribution are very, very small. And how do I know that? Again, I want to reiterate what we talked about last time for those of you that weren't here. The height of the curve essentially represents the proportion of subjects in my population with that value. So in this case, I'm likely to get samples close to 0 more frequently because the curve is high here if the null hypothesis is true. If the alternative hypothesis is true, meaning I either have a distribution to the left, so there's a decrease, or a distribution to the right, there's an increase, then if I get evidence out here, meaning the difference between them is 6 or 5 or 4 or -6 or 5 or 4, then what's most likely to have generated that? This distribution that has a very small probability at that point, or this distribution which has a very high probability at that point? The dotted one, right? So all we're doing is following the data. And that's all hypothesis testing is doing. That's why if you had a good stats teacher, they would tell you to draw the picture. If you didn't have a good stats teacher, then you got through your stats course and you never drew a picture. But I draw this picture every time for my stats students. I drew it every time whenever I was taking my undergraduate stats course, and I had to do it over and over and over again before I really understood it. So if you walk away confused, I'm sorry, I tried. But practice makes perfect. So I'm just showing you again, briefly, where these probabilities come from and why we have cutoffs and what are p-values. The null distribution is where everything comes from. The null says what? That the means are the same. The alternative distributions say that the means are different. So our probabilities, our type 1 and our type 2 error rates, actually come from different distributions. The ones that are in red, beta, and 1 minus alpha, those are actually what we use to specify our sample size. 1 minus beta, the power, comes from the alternative distribution. So there's different regions down here. If I get a value anywhere in this region from my data, so let's say, for instance, it's from -1 to +1, then I'm going to say that that evidence could have come from a reality where the two means are the same. I don't have enough evidence to say that it doesn't. But if I get out beyond that cutoff point, out here or out here, then what I am going to say is that the evidence that I got from my data is strongly enough against that reality, where they're the same, that I'm actually going to reject that reality, and I'm going to conclude that my alternative hypothesis, that there's a difference, is the correct hypothesis. Now, what I just said was in English. There was a lot of like stats terminology that was probably not exactly appropriate. You'll get people that argue over whether or not you ever accept anything or reject. So what you do here is you look to see where your evidence, your observable data, falls. Does it fall in the rejection region, which is out here in the tails, places where the evidence would be in favor of your alternative, or does it fall in the null region, where you would fail to reject? Notice that these regions are defined by alpha, they're defined by beta, they're also defined by something else that I haven't shown you. If this is 0 and I'm doing a power calculation, these two dotted curves can actually come in closer or go further out. And that's what we call the effect size. The further out they are, the more powerful your test will be. So in this case, for our specific scenario, this is a difference of 0. This is a difference of -1. This is a difference of +1. Why do I say that? If you look back, we had to actually specify 10 and 11, which gave us a difference between the two of 1. And I don't care if it's negative or positive. Okay? That's why the p-values come from the tail, because that's where our evidence against the null lies. And then you can see the size of, this is 1 minus beta, the power. If I move this dotted line, if I move that distribution out to bigger values of difference, bigger differences, what happens to 1 minus beta? It gets bigger, right? This line stays the same. More of this distribution is moved, so my power increases. So that shows you the relationship between the size of the difference that we're trying to detect and the power if you keep other things fixed. I want to briefly give you this reference. There's a really neat, Internet Explorer has stopped working. Well, I will email it to anyone who is registered rather than it's a really interactive tool that shows you, it actually shows you those things sliding back and forth and how power increases and decreases as your effect size increases. What I didn't talk about was the sample size. That was assuming a specific sample size. The sample size has an effect on power as well. And in general, these 3 bullet points are true. The less variability in your data, the greater the power you have for a given sample size. The bigger the effect size you're trying to detect, the greater power you'll have to achieve it. And increasing your type 1 error rate, alpha, results in an increase in the required number of subjects that you have to achieve a given power. Other considerations are just extra slides for you all to look at, but next time we'll actually do hypothesis testing. Hopefully some of that content will become a little bit more obvious when we do a few examples. I'll be willing to stick around if you guys have any questions. Otherwise, I will see you next Friday. Thank you.